Aloha, good evening everyone. I want to welcome you to our Queens Free Speaking of Health lecture series this evening. My name is Lisa Sakia. I'm with Corporate Communications here at the Queens Health Systems, and on behalf of Queens, I'd like to welcome you all this evening. And now, it is my privilege and pleasure to introduce you to our main speaker this evening. Her name is Dr. Victoria Wong. If you could, let's give her a round of applause. Tonight's lecture is called When Seizures Strike, What's Happening and What Can Be Done. And I'm going to give you a little bit of background of Dr. Victoria Wong. She is an epileptologist at the Queen's Neuroscience Institute Comprehensive Epilepsy Center. So what is an epileptologist? This is a neurologist who specializes in epilepsy and EEG. So what is EEG? That is electroencephalogram, which means it is a test that detects electrical activity in the brain. She is board certified in both neurology and epilepsy care. She was born and raised in Hawaii, and we always get the question, what high school you went? So she went to President Obama's alma mater, Buff and Blue, so she went to Punahou. She then went to medical school at the University of Hawaii's John A. Burns School of Medicine, and she completed her neurology training at UC Davis in Sacramento, California. She did her epilepsy training at the University of Michigan in Ann Arbor, Michigan. She was on faculty at the Oregon Health and Science University in Portland, Oregon for 4 years. It's really amazing when we see these doctors. They are going all over the place to get their training and doing their, it's amazing. And then what happens? They come back home. Isn't that fantastic? So she is happy to be back home in Hawaii, and we're happy to have her. And she's been practicing at Queens since September of 2016. She is also currently an assistant clinical professor in the geriatrics department at the University of Hawaii. Please join me in welcoming Dr. Victoria Wong.
Hi, everyone. Thanks, Lisa, for that really nice introduction. And thank you all for coming today. So, as Lisa said, today I'm going to be talking about when seizures strike, what's happening and what can be done. All right. So I don't have any disclosures or conflicts of interest to declare. I'm going to start by defining a few terms. So first of all, seizure. So a seizure is an episode that affects how a person appears or acts for a brief time. So a seizure itself is actually a symptom. It's not a disease. So just like somebody has a headache or somebody has a fever, so somebody can have a seizure. There's a lot of different ways that we characterize seizures. So this is a picture of just different ways seizures can look like. And there's a lot of ways that seizures present. Some of you may know people with seizures, and so sometimes people have actual convulsions. They fall and they shake, and often we call that a grand mal seizure. Sometimes people just stare and they zone out and have what we commonly call a petit mal seizure. Sometimes people just have shaking on one side of the body. People can have falling or drop attacks. People can have funny feelings or auras. So seizures can really look like a lot of different things, even though classically people think of falling and shaking as the most common seizure type. So when we hear this information about what seizures look like, we apply it to this classification of seizures, and these definitions seem to change constantly. There's this ILAE, which is the International League Against Epilepsy, and this is the most recent 2017 classification. So you can see that a lot of the descriptions I just mentioned, they fit nicely into these categories. Another way in which we categorize seizures is we talk about what's causing seizures, or what the underlying cause is. So there's two big categories of seizures. One of them is epileptic seizures. So this is more common that when somebody says seizure, they commonly mean epileptic seizures, so seizures associated with epilepsy. There's also this other category, though, that we see all the time. It's very common, but just among the general public, you don't hear about it as often, which is non-epileptic seizures. So when we talk about epileptic seizures or epilepsy, we're talking about an electrical surge in the brain. So something's intrinsically wrong with the brain structure that causes an electrical problem. There's many different causes of epilepsy, and generally we treat these with with epilepsy medication. This other category of non-epileptic seizures, so other names for it include psychogenic non-epileptic seizures or pseudo-seizures. So this is not an electrical brain problem. So even though these seizures look and act like epileptic seizures, when we do an EEG, so as Lisa mentioned, an electroencephalogram looking at the brain activity, we actually don't see any electrical abnormalities. So these seizures are more triggered by stress, and we recommend treatment with psychotherapy rather than treatment with medication. And very rarely, some people do have both types, and so that's why seeing a neurologist is important to make those distinctions and do further evaluation for diagnosis. So when we talk about different epilepsy categories, we gather all the information, and then it fits nicely into our schematic of what seizure types there are and what epilepsy types there are. So in this talk, because I'm an epileptologist, I'm going to be focusing primarily on epileptic seizures and epilepsy. So just like the classification of seizures, the definition of epilepsy also changes constantly based on what we know about from research studies and so forth, and also defined by this International League Against Epilepsy. So this is the current definition. There's 3 ways that you can determine that somebody has epilepsy. So one way is if somebody has 2 epileptic seizures more than 24 hours apart. So we're talking about unprovoked seizures in this case. So, technically anybody can have a seizure. So with things like alcohol withdrawal or methamphetamine usage, or if somebody gets put on a medication that can lower seizure threshold, those are provoked seizures, so we don't consider it part of epilepsy. But if somebody has 2 unprovoked seizures more than 24 hours apart, we call that epilepsy. Additionally, if somebody only has 1 epileptic seizure, but we do tests such as EEGs or MRIs, and we show that there's actually an increased risk of them having a seizure in the future, then that is also called epilepsy. And lastly, there are some very specific epilepsy syndromes, so things like juvenile myoclonic epilepsy or benign Rolandic epilepsy. So certain syndromes that we consider, if you're diagnosed with that, you also have epilepsy. So what types of epilepsy are there? The most practical way of grouping epilepsies, and a lot of this again is just categorization. So we categorize it into focal and generalized epilepsy. So these describe not what the seizures look like necessarily, but they describe where the seizures are coming from in the brain. The reason why it's important to make this distinction is because some medications are specific to one of these categories of epilepsy. So if somebody has epilepsy and they're not sure what type of epilepsy they have, certain medications can actually worsen certain types of epilepsy. That's why it's important to make this distinction. Focal epilepsy means that seizures are coming from one focus in the brain. So again, just like a lot of other things in medicine, there's a lot of different names for it. So we call it commonly focal epilepsy. This is the same thing as partial epilepsy, seizures coming from one part of the brain, or localization-related epilepsy. So when seizures come from one focus of the brain, there's a lot of things that can cause this. So for example, if somebody has a tumor in one spot in the brain, if somebody has had a stroke, if there's a blood vessel abnormality, scarring in the brain, brain injury. So all of those things can cause focal seizures. And again, I want to emphasize that just because somebody has focal seizures, that doesn't mean that they cannot have a seizure that involves the whole body or a generalized seizure. The seizure can spread from that one focus to cause a generalized convulsion. So some of this terminology is a little bit confusing. There's another type of epilepsy called generalized epilepsy, and what this means is that seizures come from more broader brain networks that involve both sides of the brain. So usually, kids are more likely to present with generalized epilepsy, and it's more likely to have a genetic cause rather than an acquired cause, such as a brain tumor or a stroke. So that's the other type of epilepsy that we talk about. So now I want to pivot to talking about seizure safety. So I feel like seizure safety, people often put this at the end of talks, or doctors bring it up at the very end of the appointment, but it's actually very, very important. So I wanted to put it in the middle of the talk to focus on this. So if somebody has seizures, how do I stay safe if I have seizures? And I'm talking about either epileptic or non-epileptic seizures, because both seizure types, the person who's having them doesn't have control over their body when the seizure is going on. The second question is, what do I do if I see somebody who has a seizure? And the third question, when is a seizure an emergency? So if you or somebody you know has seizures, it's very important for them to address all of these issues with their physician, with their neurologist. So driving is something that comes up a lot. So if somebody has had either one seizure or somebody has epilepsy and they have frequent seizures, so by Hawaii state law, you actually cannot drive for 6 months after you've had any episode where you lose consciousness. So not just seizures, but fainting or other things that can cause loss of consciousness. So that's Hawaii state law. So sometimes neurologists make the decision that sometimes it's not safe to drive unless somebody goes a year without a seizure, or basically a longer duration if it's felt to be unsafe. Sometimes there are exceptions where if somebody only exclusively has seizures in the middle of the night, then it may be reasonable for them to drive. So all of these things are kind of customized for everybody who has different seizure types. It's important to be safe around water because there's a drowning risk. So we usually recommend avoiding taking baths and avoiding swimming or having very close supervision when swimming. It's important to talk about fire safety with cooking, safety at home, such as keeping the bathroom door unlocked, and kitchen safety, making sure the smoke detectors are in place. We also counsel about things like not climbing ladders and worrying about operation of heavy machinery. Contact sports is a question that comes up, especially among children with epilepsy or children with seizures. And then childcare. So if you have like a young baby and you're taking care of the baby and you have seizures, there's a risk of falling and dropping the baby or something like that. So it's important to talk about all of these issues. If you see somebody having a seizure, then what do? So the first thing is, you're not going to be able to stop the seizure. There's no way to stop the seizure immediately. So what you want to do is just be there to keep the person safe, and you want to stay until the seizure is over and the person having the seizure is safe and back to their baseline. You want to make sure that they're breathing okay. So sometimes bigger seizures can affect breathing. So one thing that we ask people to do is the person who's having the seizure, you want to turn them on their side so that if they're drooling, then the saliva falls out of their mouth and they don't aspirate or choke on their saliva because they may not be able to control that. One thing that's helpful is to time the seizure. So from start to finish, how long is the seizure itself? So sometimes people are confused or tired after a seizure, so not timing that part of it, but timing how long either the convulsing or the seizure itself lasts for, because as you'll see in the next slide, that may be helpful to determine whether a seizure is an emergency or not. You don't want to put anything in the person's mouth who's having a seizure, because people can, bite things and choke on it, so that can be dangerous. And then lastly, if somebody has known epilepsy, sometimes people have what we call a rescue medicine. So they take a medication to try to prevent the seizure, to prevent future seizures, or if somebody's having a very prolonged seizure, to even try to stop that seizure as it's happening. So if that's something that that person has, then you may want to administer it if it's appropriate. This is just an example of if somebody has a big convulsion and falls, what that may look like. And so you can see that the appropriate thing to do is to turn that person's head, unless they've had some sort of neck injury. If you're worried about that, you don't want to do that. But just having the person on their side so that they're not choking on their saliva, and so that they can breathe a little bit more easily. So finally, when do you call 911? When is a seizure an emergency? So if a seizure lasts for 5 minutes or longer, we consider that a medical emergency. There may be exceptions. So if somebody has very, very bad epilepsy and they have long seizures all the time, then it may not be appropriate. But in general, if somebody has a seizure lasting for 5 minutes or longer, you want to call 911. If somebody has back-to-back seizures without recovery, so they have one seizure, they're still confused or not waking up, and they have a second seizure, we consider that an emergency. If anybody has breathing or choking problems, then call 911. If there's any serious injury that has happened, any broken bones or dislocated shoulders or anything like that, call 911. If it's a pregnant woman who had a seizure, or just any time you feel uncomfortable, any concerns, you can call 911 to get immediate medical help. So one question people ask, so people who've been diagnosed with epilepsy, is, will my seizures go away? So the first step is always to make sure that the diagnosis is correct. So some people, they've been diagnosed with epilepsy and they try medicine after medicine and it's not helping. So the first thing to do is to make sure that this is epilepsy that we're talking about, and not something like non-epileptic seizures or, a heart problem or something else. And then also making sure it's not non-epileptic seizures. But if the diagnosis of epilepsy has been confirmed, about 2/3 of people with epilepsy will have easily controlled seizures. So you can start a seizure medication, and once they take it, the seizures are actually well controlled and go away. Unfortunately, there is about 1/3 of patients who are diagnosed with epilepsy who have refractory epilepsy, meaning that it's difficult to treat despite trying a number of seizure medications. And that's the bulk of my practice, is this more challenging group of patients. So ultimately, the goal is for patients to have no seizures and no side effects. That's always the goal we aim for. But unfortunately, with the refractory epilepsy group, this is a little bit more difficult, even though we try. There are many epilepsy treatments. Epilepsy medicine is usually our first go-to, but there are also epilepsy diets, such as the ketogenic diet, the modified Atkins diet, or the low glycemic index diet. There's epilepsy surgery, there's vagus nerve stimulation, and also responsive neurostimulation, also known as NeuroPace. So any one of these topics could fill a whole hour of a talk or a textbook. So I'm not going to go into these in great detail, but just so you know, these are the categories we have to work with. Seizure medications, you can see from this chart that there are a lot of seizure medications, but that wasn't always the case. So if you look at the timeline at the bottom, you can see that 1912 is when phenobarbital first came out. That's our oldest seizure medication that we still use today. But over the years, and you can see especially after 1990 and after 2000, there have been many, many new seizure medications that have come out. And in general, the new seizure medications do have fewer side effects than most of the older seizure medications. just focusing on medication since 2010, you can see that these are the new and approved medications. So in 2011, clobazam, or Onfi, was approved by the FDA, the Food and Drug Administration. In 2012, oxcarbazepine extended release. So we've had oxcarbazepine for a while, but there's Oxtellar XR, which is the extended release formulation that has come out. Perampanel or Fycompa is another medication that has a new and different way of working compared to older medications. In 2013, we had an extended release version of topiramate come out, so under the brand names of Trokendi and Qdexy. There was also eslicarbazepine, which is Aptium. So that's a version of oxcarbazepine that's a little bit more pure as far as the chemical structure goes. And then in 2016, most recently, we have brivaracetam, which is Briviac. So this is a variation of levetiracetam, which is Keppra. So one question that always comes up is, what about medical marijuana? So in general, and some of you may be familiar with this because there was that Sanjay Gupta documentary. So in general, marijuana has two major components. There's THC, which is the component that's psychoactive or can make people high. But what they're really looking at as far as epilepsy treatment is this other component, which is CBD, which is cannabidiol. So cannabidiol, there have been a lot of studies showing that there was a potential beneficial effect of cannabidiol on seizures. And there is a drug company that basically purified cannabidiol into a 99% pure oil-based extract, and that's under the brand name of Epidiolex. So right now there is ongoing research. Unfortunately, there are no centers in Hawaii who are doing these clinical trials, doing this research, but on the mainland there are undergoing trials that are researching Epidiolex in a number of conditions. For now, they're mostly focusing on treatment of children who have these very, very severe types of epilepsy where they may have up to dozens of seizures a day. So Lennox-Gastaut syndrome, Dravet syndrome, tuberous sclerosis, and just refractory epilepsy in general. But for now, they're looking at kids more than adults. This is very new ongoing research. So just recently, there was a study published in August 2017 looking at Dravet syndrome, which is one of those really severe infant epilepsies that start in infancy. So in Dravet syndrome, what they found was, so they compared people taking the CBD oil, and then half the group got placebo, which is usually like a sugar pill. In this case, probably an oil resembling the Epidiolex. So in a lot of epilepsy studies, one thing that they look at is the responder rate. So how many, so basically a responder is somebody who has seizures drop by 50% or more. So when they compared CBD and placebo, they found that 43% of patients on the CBD oil responded, whereas 27% of people on placebo responded. And there was a statistically significant difference between these two groups. The study, there was good news and bad news coming from this study. The good news is that it's finally proof that CBD, cannabidiol, actually can help seizures. But on the other hand, I think a lot of people were hoping that CBD oil for the treatment of epilepsy, they were hoping that it would have fewer side effects because it's thought of as a more natural substance. Unfortunately, there were a fair amount of side effects with patients who are on the Epidiolex. So there was reported diarrhea, vomiting, feeling tired, fever, abnormal results on liver function tests. Overall, it was actually a pretty high percentage, like greater than 50% who had side effects, but as with all medications, some of these were more mild, so just feeling a little bit sleepy, and then some of these were more severe side effects that required dose reduction or stopping the medication completely. So another way to treat epilepsy is epilepsy surgery. So like I said, in that 1/3 group of patients who have difficult to treat epilepsy, epilepsy surgery may be one way to try to reduce seizures further or even make seizures go away. So this involves surgically removing the part of the brain where seizures are coming from if medications are not working. There's a lot of questions that we need answered before we can pursue epilepsy surgery. So for example, we need to know where in the brain are seizures coming from. So if somebody has generalized epilepsy or if somebody has seizures coming from many spots in the brain, we wouldn't be able to do surgery. Another question is that part of the brain safe to remove? So sometimes we pinpoint where seizures are coming from, but we determine that that's a part of the brain that's actually responsible for motor function or speech or something that you wouldn't want to injure. So that's another important question to answer. And then we always talk about, after we do all the studies such as MRI and EEG, we talk about what are the chances that the surgery will help the epilepsy, and then what are the risks of doing brain surgery on epilepsy. When we talk about doing this pre-surgical evaluation for epilepsy, it involves a lot of steps because we have to get very thorough information before we pursue epilepsy surgery. So we bring people in for inpatient epilepsy monitoring where we put EEG electrodes, so a lot of wires on the head just to monitor the electrical signal so that we can record seizures, both the brain waves and the video when somebody's having seizures so that we can see what the seizures look like and potentially pinpoint where they're coming from. We have a high resolution MRI scanner so we can look for any brain abnormalities. Sometimes we do a PET scan or a SPECT scan if the MRI doesn't show anything. We also do neuropsychological testing, which is memory testing and cognitive testing to test different parts of the brain to see if the part of the brain where the seizures are coming from is affected more strongly or is more impaired than the rest of the brain. And then lastly, we have a monthly epilepsy surgery case conference where a multidisciplinary group, so a group of epileptologists and neuroradiologists, neurosurgeons, neuropsychologists. So a big team of people come together to talk about each potential epilepsy surgery case to see if what the best plan of care is for surgery. Sometimes when epilepsy surgery is not an option, there's another device, there's a device called NeuroPace, and this is a very new technology. It was just approved by the Food and Drug Administration, the FDA, in 2015. So they've been talking about this for about 15 years now, and it's actually been in place for about 8 years. So there's actually lots and lots of information from research studies, but it's just now in the past 2 years that we've been able to implant this as an approved device. So what NeuroPace is responsive neurostimulation. It's an implanted device in the brain where, for example, if somebody has seizures that are coming from the motor area of the brain and we're not able to do surgery, because if you take out that area of the brain, you might become paralyzed on one side of the body. So one thing that we can do is actually place an electrode or multiple electrodes that go to those affected areas. And the idea behind NeuroPace is that you're constantly recording basically EEG signal from that area of the brain, and then you're trying to send an electrical signal to stop the seizure before it can have a chance to spread. So this little squiggly line at the bottom is an example of how NeuroPace works. So on the left side, you see that there's normal brain activity, and then there's unusual activity that's picked up by this device, by these electrodes. And then it actually sends treatment. So it sends an electrical signal. And then after that, the idea is that brain waves normalize. So this device doesn't get rid of seizures completely, but it actually can significantly reduce the number of seizures if resective brain surgery is not an option. So this is an example of what NeuroPace looks like. You can see that there's, in some cases, there's a wire going directly into the area of the brain that the seizures are coming from. In some cases, there's just a little strip of electrodes. And then what you're seeing, the actual device, that's actually the battery pack, and also it can hold a certain amount of information. It's basically like a hard drive also. And that device replaces a piece of the skull so that you can't really tell that anybody has that device. It's just, it fits in nicely. So who gets epilepsy? Basically, anybody is at risk of developing epilepsy at any age. It can happen at any time. And of course, all races can be affected. In general, so 1 in 26 is the number that we hear a lot. 1 in 26 people will get epilepsy at some point in their life. Yeah, and then this is the same slide as before, just showing that there's a wide diversity of ways that of what epilepsy can look like. This is another graph just showing the age of patients who get epilepsy. So this bottom, the x-axis, the horizontal axis, is the age in years. So going from 0 to 100 years old, and then the y-axis, the vertical axis, is the rate of developing epilepsy. So you can see that we call this a U-shaped curve because that blue line is shaped like a U. So before age 10, there's a lot of new onset epilepsy. So these are all the congenital genetic cases of epilepsy that come in childhood. And then, even throughout people's entire lifetimes, epilepsy can happen, but it's pretty much after age 70 when the risk goes up again and goes very high because there's acquired causes of epilepsy. So people who have had a stroke or people who have brain tumors, or even things that we don't as commonly associate with epilepsy, things like Alzheimer's, dementia, can also be linked to epilepsy. So that's why that rate goes up in later years. So even though anybody can get epilepsy, at different, there's definitely special populations that we want to focus on, and because there are special issues that can come with different populations. So one thing is age. So youth with epilepsy, when very young people get epilepsy, there are different things to focus on as far as social impact. So, having to go to school, having to go to things like sleepovers, having to participating in things like sports. There are special issues that come up with very young people with epilepsy. There are issues sometimes with compliance. So as they're making a transition to independence, whether it's going to college or just growing up and moving out, making sure that they're taking their medications. There's also issues related to seniors who have epilepsy because they're more likely to be on different medications that can have side effects when combined with epilepsy medicine. It's very important to look at drug interactions. Sometimes these people have medical issues such as liver or kidney problems or other things that can affect either the epilepsy or the epilepsy medication. There's a higher risk if somebody falls. So if somebody has osteoporosis, it's more likely that they'll break a hip or something if they have a seizure and fall. And then there's also loss of independence. If somebody is having uncontrolled seizures where they lose consciousness or if they're not able to drive, there are issues associated with that. So women who have epilepsy, so this again could fill another talk or another textbook, but there's definitely special issues that we consider as far as women with epilepsy. Folic acid supplementation is important because with all seizure medications, there's an increased risk of birth defects. Bone health, just because of the higher osteoporosis risk, is important to address. There's hormone effects, so hormones in the body just estrogen and progesterone have different effects on epilepsy. So if there's a very strong link between menstrual periods and seizures, we call that catamenial epilepsy. There's also effects of taking hormones. So hormone replacement therapy or contraception, those are things to take into consideration as well, because they can affect seizures, they can affect seizure medication, or the seizure medication can make contraception not work, things like that. So very important to address all those issues. And then, again, interactions with other medications, and then menopause is another thing to think about as far as women with epilepsy. Even though there's all these issues, one good piece of news is that women who have epilepsy in general, more than 90% of their pregnancies result in healthy babies. So a lot of times women who have epilepsy, they worry about these birth defects that can happen with medication, and they worry about having seizures while they're pregnant, but it's actually very optimistic information about having a kid, having a baby if a woman has epilepsy. Also, veterans are a special population because there's a very high incidence of traumatic brain injury, and so post-traumatic epilepsy is a very different entity with other considerations, and post-traumatic stress disorder actually ties into diagnosing epilepsy and seizures in this group of patients. And then lastly, people with other medical conditions. So I touched on this briefly, but if somebody has epilepsy and they also have heart problems or liver or kidney problems, if somebody has a brain tumor, traumatic brain injury, mood issues, osteoporosis, or reproductive issues, sometimes these things can be very closely linked with medications or the epilepsy itself. So very important to address all of these different things. So just wanted to talk a little bit about our Queens Medical Center Comprehensive Epilepsy Center. So we're the only NAEC accredited center in Hawaii. So NAEC, it's the National Association of Epilepsy Centers, and they're basically a regulatory board, and they require a certain number of, in order to get accreditation, there are certain standards that we have to meet, and we're actually a level 4 center. So this is it's the highest possible center, or the highest possible level that a center can be. Additionally, so Dr. Stein and myself, Dr. Stein's the epilepsy director of our center. So the two of us are the only ABPN board certified epileptologists in Hawaii. So what that means is the ABPN is the American Board of Psychiatry and Neurology, and so they're basically the board that provides board certification in certain specialties. And so there's a specialty that's epilepsy, and we have to take a board exam every 10 years and get a certain amount of education on epilepsy every year so that we're really keeping up on what's new in epilepsy. So, and then last but not least, so Natalie, I think Natalie's sitting there in the back row. So can we, all right, so Natalie is our nurse practitioner. She's wonderful. She's not just involved in education and counseling of our patients, but also quite involved in community events, and some of you might recognize her, but also helps coordinate our epilepsy center and basically makes it run. So we have a very great team that I'm happy to be working at this center. So our contact information, that's in your handout. And just some resources. So epilepsy.com is a very, very good resource. It's a website that's created by the Epilepsy Foundation. All of the content on that website is actually written by epileptologists. So, sometimes not all the information you see on the internet is accurate, but that website has very good detailed information about epilepsy that you can read about. There's the Epilepsy Foundation of Hawaii, which has lots of great events all the time in support of the epilepsy community in Hawaii. And then some of these other associations are things that I mentioned in my talk. So that's all I have for today.
Okay, thank you, Dr. Wong. At this time, I'll have her take a seat, and then if you have any questions, please go ahead and raise your hand, and we'll come down into the audience.
Hi. Can you tell me if acupuncture is of any help in treating epilepsy?
So the question was whether acupuncture is helpful in treating epilepsy. So what we know at this point is that there have not been any formal studies that have shown that it helps. So in general, epilepsy is what we think of as an electrical problem of the brain. And so a lot of the therapies that we talk about are really trying to reduce that amount of abnormal excitable electrical activity, and they haven't been able to find a link yet between acupuncture and reducing that abnormal electrical brain activity. So it's something that you can certainly talk to your neurologist about if you feel like it's helpful, and it may be helpful in other areas, but not specifically helping with epilepsy.
Hi, Dr. Wong.
Hi.
Do seizures affect memory, ability, as well as recall?
Yeah, so the question is whether seizures affect memory ability and recall. That's a really great question. So the answer is unfortunately that it does. Seizures can affect memory significantly. We know that the parts of the brain that seizures come from, those are areas of the brain that are very strongly associated with memory areas. And so especially people with certain epilepsy types like temporal lobe epilepsy, that's a part of the brain that seizures very commonly come from. People do notice a decline in memory over time. One thing that we do is something called neuropsych testing, which I mentioned earlier, which is really testing memory and cognition and seeing if certain parts of the brain are affected more than others. So it's not just the seizures that can cause a decline in memory over time, but sometimes seizure medications can also affect memory. So certain medications can either make people think a little bit more slowly, or somebody is on a lot of medications or different combinations of medicines, like not just epilepsy medicines, but just medications in general, that can definitely have a big effect.
Question here.
Oh, I was wondering, in gymnastics and yoga, when you suddenly overextend your neck, can that lead to seizure or stroke?
Yeah, that's a good question. So the question is if somebody's doing yoga or gymnastics or something where they hyperextend the neck, whether that can lead to seizures or stroke or other issues. So there's no direct link between that and seizures specifically, or epilepsy specifically, because epilepsy comes from the surface of the brain, the cortex. So the brain has sort of the internal, like the white matter, and then the covering of the brain, which is the gray matter. And we know that when the surface of the brain is affected, that's where seizures come from. So if you're talking about moving your neck around, that's not going to cause seizures specifically. There are other things. So there are some very delicate blood vessels in the neck, and so sometimes, very rarely, but if those small little blood vessels are injured, that can lead to a stroke or other problems. Okay.
Yeah, I have a question regarding concussions.
Mm-hmm.
Could someone had a concussion be susceptible to epilepsy, and how would that be treated?
Yep. So the question is if somebody has a concussion, if that makes them more susceptible to epilepsy, and if that's treated a certain way. So when somebody has a concussion, there are a lot of symptoms that can happen. So there's post-concussive syndrome where people can get headaches or memory problems or dizziness, all sorts of things. However, for brain injury to cause seizures, that involves a little bit more severe brain injury. So we know that in order to really have brain injury and be at higher risk of having seizures, there has to be either prolonged loss of consciousness, so having loss of consciousness for half an hour or longer, or bleeding in the brain, because the having blood in the brain can be an irritant and cause seizures, or have skull fracture. So it really takes a lot, pretty strong head trauma to actually induce epilepsy.
This question is about the NeuroPace.
Mm-hmm.
How long does it last before it has to be replaced? It is battery operated.
Yep. So that's a good question. The question is with NeuroPace, the battery for NeuroPace, how often that has to be replaced. So on average, the battery I would say lasts about 3 to 4 years, but it's also dependent on how often it goes off. So somebody who has abnormal brain activity all the time or seizures all the time, if that NeuroPace device is triggering all the time and sending signals, then that battery life is going to be much shorter than somebody who has, say, 2 seizures a month and the NeuroPace doesn't go off very often. I know that there's another generation of NeuroPace coming out where I think people who are replacing their batteries in the next few years, it's actually going to be extended to an 8-year battery life, which is very good news.
Other questions? Raise your hand.
For some reason, they fidget. They cannot stay still. Is there a reason for that?
I didn't catch the first part. So you were saying that something
they
cannot stay still?
Yeah, they fidget. I mean, they cannot sit still and just listen. They have to fidget.
Oh, are you talking about audience members or who cannot
No.
stay still and has to fidget? Or during a seizure?
No. Just normally.
Oh, people who have seizures.
After, yeah. But I mean, in a normal day, I mean, when they have to listen to someone
Uh-huh.
and they can't stay still like we do.
Okay.
I mean, they're fidgety. They need something to do with the hands.
I see. So the question is, why is it that people who have had a seizure or people who have epilepsy have a tendency to be very fidgety after they've had a seizure? Is that the question?
No, doesn't have to be after.
Okay, just in general.
Yeah.
So there's a lot of different things that could potentially cause that. So, one thing is, if sometimes medication side effects can cause people to feel a certain way and be more fidgety. We know that the parts of the brain that are involved in seizures are also parts of the brain that those parts of the brain are generating seizures because they're not working right. And so that can also have other side effects. So there can be like an increased risk of like attentional deficit disorder or ADD. So in that case, it may be that the person who's having epilepsy also has another condition where their attention span is affected and fidgety in that sense. And then sometimes just recovering from a seizure, that the brain has been affected. You've basically had an electrical surge in the brain. And so that itself can also cause people to not be quite themselves.
Okay, other questions?
I have a about the newer medications, and then you mentioned very briefly Keppra, which I understand is a older one that's been around for a while. I wonder if you could expand your comments on Keppra, please.
Yeah, so the question is why I brought up Keppra when talking about the medications that have come out since 2010. So I was talking about that actually in relationship to brivaracetam, which is in the same class of medicine as Keppra, but it's different from Keppra. So Keppra, the generic name is levetiracetam, but the new medicine that just came out in 2016 is brivaracetam. So the brand name for that is Briviac. So this medicine, it's pretty similar to Keppra. They've actually done some studies showing that it's actually not as effective as Keppra, but very, very slight difference. But the idea behind this is that there might be some benefits to it. For example, Keppra, some of you may know Keppra can cause some either moodiness or agitation or anger issues. That's one of the Keppra side effects, and there's a thought that those side effects may be improved with a switch to brivaracetam.
Okay, other questions? If not, we'll go back to one more person.
I was wondering, at what temperature should a fever be treated with Tylenol or other medication in a child to decrease the chance of a seizure from the fever?
Okay, so the question is, if a child has a fever, at what point would you want to treat that fever? So if somebody has, there's this condition called febrile seizures. So when kids have a very high fever, some of them actually can have a seizure because of that. And usually when that happens, there's no long-term consequences. Unfortunately, I'm not a pediatrician, so I'm not the best person to ask, and it's probably different in different situations. It kind of depends on what's causing the fever, and so I would defer to a pediatrician to answer that question. Okay.
Oh, one question over there.
Thank you. I'm interested in the relationship between strokes and seizures. And when you were talking about when to call 911, I have a hard time distinguishing whether it's a stroke or a seizure. And I know that stroke scars are sometimes the cause of seizures, but I sort of err on calling 911, and I don't know whether I could identify just a seizure. We have both conditions.
Yep, so the question is about distinguishing between a stroke and a seizure and when to call 911. So I would recommend that if somebody is having neurologic symptoms for the first time, so whether they're having, so things that we associate with stroke would be sudden weakness on one side of the body or slurred speech. So if somebody is having those symptoms and they've never had them before and you don't know what they are, I would call 911. Likewise, if somebody is having a seizure and that person has never had a seizure before, I would also call 911. If this is something that happens regularly, so somebody has sudden neurologic symptoms and it's happening on a weekly basis or a daily basis, and then I think that's a more customized decision that you would have to discuss with your doctor about when it's appropriate to call 911 and when it isn't. In general, I would say that anything that's new and anything that's concerning to you, so if somebody has a neurologic condition and you're thinking, this is not normal, this has never happened before, then I think that what you said, erring on the side of calling 911 is definitely appropriate.
Oh, one more question here.
I have a question regarding the epilepsy treatments and the diets. Where do we find out more about those, that ketogenic and such, Atkins?
Yeah, so the question is about epilepsy diets. So I didn't go very much in detail on those, but there are some epilepsy diets, and the idea behind most of them is basically increasing fat intake and reducing carbohydrate intake, because we know that when that happens, the body kind of goes into this starvation state, and so it produces something called ketones that can actually be anti-inflammatory, and there is scientific data that shows that it can help with seizures. It's usually in somebody who has very, very severe epilepsy with frequent seizures, and not necessarily somebody who is easily controlled on a seizure medication. As far as where to get more information, so we do we do have resources in our epilepsy center. Natalie works with our nurse practitioner works with a lot of the patients who are on epilepsy diets, and we also work with a dietitian who can help educate about these diets.
Okay, any last questions?
What advice would you give to, say, coaches or athletic directors for their students or athletes that have epilepsy?
The question is, what advice would you give to coaches who have athletes who have epilepsy? So I think that that's a very kind of customized thing depending on the type of seizures and the type of epilepsy that the athlete has. In general, there's a distinction between contact sports and non-contact sports. So definitely somebody who wants to play football, for example, the restrictions are much tighter than somebody who wants to play tennis, because you can imagine that the difference in the degree of potential injury is very different between contact sports and non-contact sports. Swimming is something in particular that's a bigger risk, because even somebody who has a brief 10-second staring episode, if they have it while they're underwater, that's a drowning risk. So it really depends on how well the epilepsy control is. So somebody who doesn't have any seizures when they're controlled on medication, that counseling is going to be much different compared to somebody who has regular seizures and just wants to get some exercise.
Okay, thank you. Let's give another round of applause for Dr. Victoria Wong for sharing her time this evening. I also want to say mahalo to Naomi Manuel, who is the Executive Director of the Epilepsy Foundation of Hawaii, and our Natalie Morgan Romaine, who was the Epilepsy Care Coordinator at the Neuroscience Institute, and they were out there in the front, so when you came early, all that great information and getting to talk story with them. Let's give them a more round of applause as well. And I also want to thank, it's kind of like one of those speeches like receiving an Oscar, but I want to thank our Queens volunteers who Wednesdays, they give up their time, and that's Karen Sumida and James Liu in the back. Oh, she's outside already. And our next Speaking of Health lecture, this is a great one. You know how we're going through all these stresses, especially with the holidays coming up, but even without the everyday stress, if you want to talk about things like job loss, tragedy, how can you deal with all of those issues? We're going to talk about resilience. And we have Queen's Chief of Psychiatry who's going to be talking about it, techniques that we can use and apply to our own lives to see how we can better deal with things that are the slings and arrows that come upon us, and how we can build our inner strength. That's going to come up November 15th. Usually our Speaking of Health are toward the end of the month, but because of the holidays, everyone seems to disappear as it passes Thanksgiving. So November 15th is when we're going to have that. It's called Overcoming Life's Challenges, How to Build Resilience, and that is going to be from 6 to 7 right here at the Queens Conference Center. You can register online at queens.org, click on Attend a Class, or call the referral line at 691-7117. That's going to do it for us this evening. You can do your evaluations and send it out, turn it in the front. Don't forget your parking validations. Get it done with Erin at the front. And thank you so much for coming this evening. Have a good night.